So I want to thank you all for having me come back again to give a presentation. This is a really exciting topic. I want to start by saying I have an immense amount of respect for Dr. Wolf. I've worked with him for several years at this point, but I will say that I found the last slide that he presented to you all personally offensive. We can all be so lucky to wake up and realize that we picked the Cubs. So I'm wearing my Cubs blue. Don't hold it against me. But all right, so we're going to be talking about for the next about 35 minutes. I'm going to try to keep this as brief as possible, which some of you may know that it's a bit of a challenge for me to keep things concise. Understanding the psychology and neuroscience behind traumatic brain injury. When I was told that I was going to give this presentation, I was planning this in my mind. I'm thinking, okay, in the first hour I'm going to talk about this. Second hour I'm going to talk about that. And think, oh no, we've got 40 minutes or less. So I'm going to try to cram a lot of information in a short period of time. I believe you all have my slides or have access to my slides. I think they're fairly detailed. There are going to be some things that I'm going to gloss over. So bear with me. Just in the interest of time, I'm going to get to some of the high points. Talking about traumatic brain injury is something that, is very much a big part of my life. Every time I give this presentation, I think back about being in graduate school and learning about traumatic brain injury for the first time. And this really wasn't all that long ago, but what we were talking about at that time was really more along the lines of moderate severe brain injury. That was sort of the population that had been identified as survivors from this type of particular condition. There's so much more discussion now in some of the different types of injuries, blast injuries related to the war, sports concussions. All these kinds of things are really in the public awareness now. So we're talking about traumatic brain injury far more than we ever did in the past. And I've always reminded of this example of my home life, which I want to share with you. I've said this in other presentations before, but when I think about defining traumatic brain injury and where we've come in our culture, I'm reminded of a time a couple years ago at home. My son, who is now 10, he was about 7 at the time, comes up to me and says, and he's in a panic, and he says, oh my gosh, Abby, my daughter, his sister has a traumatic brain injury. And what are we going to do about it? Dad, I know about the neuropsychological, the psychological consequences, and oh my gosh, long-term morbidity, this, that, and the other. And, of course, I get the stern look from my wife, saying, okay, Eric, be careful what you say to these kids, because they listen to it. So what happened was my daughter was playing around, she was doing some gymnastics at the time, and bumped her head. And so she hit her head, she was perfectly fine. But I thought that was a really interesting example of sort of where we've come in our society as far as identification of this type of injury. Way back when, this was overlooked. The base rates were a significant underestimate of how frequently this is occurring. Now, seemingly, the pendulum has kind of swung the other way, where some would argue maybe there's even some over-identification. But, it's for everyone else to decide which is better, under-identification or over-identification. I think it's probably good that we identify folks when they're having the injury, if they're having the injury, and get them the services that they need in a timely manner. So when we're talking about traumatic brain injury, of course, this is what I shared with my son. I said, well, actually, Jake, my son, not all blows or jolts to the head result in a TBI. But when we're talking about traumatic, and we're comparing that to acquired brain injury, we're really talking about the mechanisms of injury, or the cause of this neurological dysfunction. Of course, when we're talking about traumatically induced brain injury, we're talking about some type of external force acting on the head in comparison to an acquired traumatic brain injury, which is a result of some sort of internal process that is causing this change, which is commonly referred to as like stroke, those types of injuries. But as I stated earlier, not all blows to the head or jolts to the head will result in a traumatic brain injury. The severity of these types of injuries exists on a continuum. So on the one end, we have mild traumatic brain injury, and some people have a hard time saying, well, we're talking about a traumatic injury, and you're calling it mild. Of course, we're referencing it in comparison to a moderate or severe injury, and really the delineation is based on some severity indicators such as loss of consciousness, degree of post-traumatic amnesia, and so on. So we're talking about this phenomena existing on a continuum. And it can result in short or long-term problems. A lot of the folks that we see in our clinic are those that have incurred more of a moderate to severe type of injury, which suggests that they may have longer-term effects in multiple different areas of functioning, some of which I'm going to be discussing in just a little bit. So I leave this slide. I realize that this data is 21 years old at this point. I understand that. That's not really the point of this message. But I'd like to leave this in this data point from the Brain Injury Association that direct medical costs and indirect costs, such as loss of productivity associated with TBI, total an estimated $60 billion in the United States in 1995. And I had given this presentation, or a variant of this presentation, somewhat recently, and someone in the audience had more of an updated number. And surprise, surprise, it's higher than 50, or it's higher than 60 billion. So this is certainly a condition that is affecting so many of us around us and the community as a whole. Long-term consequences. So I leave this slide in here because when you look at what some of the lingering effects of traumatic brain injury as reported by the CDC, you'll notice that this is a different condition than some of the other types of medical disabilities that we may be familiar with. And what we see is some of the lingering effects have a physical, a psychological, a psychiatric, a neuropsychological effect. And these are the struggles that survivors of brain injury are facing day in and day out. So we could spend a whole lot of time talking about the pathophysiology of traumatic brain injury and what are the substrates to account for some of the changes that we commonly see. That is certainly beyond the scope of this presentation, but what I want to emphasize here is that these are not random changes in the brain. Now, I left with, or I want to leave you with the idea that once you've seen one brain injury, it means you've seen one brain injury. And what that means is there's a lot of individual differences. That being said, there is some degree of predictability. There is some pattern that we commonly see from one survivor to the next. And we see some of these effects circumscribed to certain areas, and more specifically some of the orbital frontal regions of the brain, the anterior temporal lobes, and so on. And I'm going to explain a little bit of that here in just a little bit. So suffice to say, these injuries, although are often referred to as diffuse, are not necessarily diffuse. There is a characteristic pattern that is commonly seen following a traumatic brain injury. Getting those reversed. So this is just an illustration. This is a cross-section of the contents within inside the cranial vault. I'm not going to go into great detail. The reason why I wanted to keep this up here is because you can see that this is a fixed space. There's a lot going on here. We have various types of tissue. We have gray matter around the surface, white matter internally. We have blood vessels. We have protective layers, and so on. So this environment needs to stay stable and intact. And there is a problem if anything new is introduced into that environment because there's no place for the brain to go but down. And that can be very problematic, as I'll explain here in just a little bit. So when we're talking about traumatic brain injury, we've defined what it is. Now it's time to talk a little bit about the types of traumatic brain injury. So what I've referenced here are closed head injury, which tends to be more common, an open or penetrating head injury, and really what we're seeing a lot of now are these blast percussive injuries, which have been identified as one of the signature injuries of the war. So we also, just as a quick aside, our clinic here at the university sees a lot of patients from a lot of different referral sources, okay? So we're seeing patients that are being referred to us from Dr. Wolfsafe, for instance, from physical medicine and rehab, neurology, family practice, and so on. We also have a lot of our clinic dedicated to the evaluation of active duty military. So we're seeing a lot of soldiers that are coming up from Fort Leonard Wood, many of whom have the combination of traumatic brain injury and post-traumatic stress disorder. That's a whole different topic that we would love to be able to get into, but unfortunately we don't have the time this morning to really delve deeply into it. But suffice to say, that is really a common comorbidity that we're seeing more and more of. So what is closed head injury? So this is one of the most common types of first injury or first degree injury, and I'm going to explain that in just a little bit. There is no penetration of the skin or open wound. These are due to the rapid acceleration, deceleration, or rotational forces. So what I wanted to describe for you all this morning, the difference between acceleration and deceleration injuries. So acceleration is when the head is relatively motionless and then struck by a more rapidly moving object. And we see this a lot with patients who come in who are the victims of an assault. They've been hit in the head with a fist, a baseball bat, those types of things. Deceleration injuries is when the head itself is moving rapidly and strikes against a fixed or stable object. Okay? So someone's head hitting the wall, those types of things. When we see folks that are coming to us following a motor vehicle accident, oftentimes there's a combination of these different forces at play. The brain is moving around inside the skull. You know, I think the best analogy that I have here for a closed head injury is if I were to have a basketball and I were to bounce it up against the wall, you have a point of impact and then you have a counter point of impact, and it's ricocheting back and forth, and that's causing a lot of injury to that brain tissue inside. And then there's twisting movements, rotational movements that can also be a source of pretty significant morbidity. Okay, so what I described with the basketball analogy is what's commonly referred to as the coup-contra coup effect. So that initial point of impact, if I were to take the basketball and hit it up against that wall, that initial point would be the coup, and then the contra coup would be the diametric rebound. So it's when it's bouncing against the opposite wall. Okay? When we're talking about open or penetrating injury, that's really when the cranial wall is disrupted. Okay, so those protective layers have been penetrated, lacerated. A lot of times the cause of those may be gunshot wounds, stabbing, those types of things. When we look at the differences, and I won't go a whole lot of detail in this presentation, but when we look at the differences between a closed head injury and a penetrating brain injury, penetrating for the most part usually results in some type of circumscribed or direct, predictable path of injury. When we're talking about a closed injury, there is a demonstrated just a little while ago. The contents are moving all around, and there's all kinds of diffusely distributed effects. Again, there is a pattern often to that, not necessarily as predictable as we would like it to be, but those effects, relatively speaking, do tend to be a little bit more diffuse. Of course, I'm referring to the penetrating brain injury having those circumscribed effects in those that live. Obviously, there's a higher rate of mortality that can go along with those penetrating brain injuries. Okay, and certainly there's a higher risk for post-traumatic seizures with a penetrating injury. I don't know if Dr. Wolf talked about seizure management during his presentation, but that's not to say that there isn't a risk for post-traumatic seizures that go along with closed head injury, but there's certainly a higher risk of penetrating because the cranial wall, the contents of the brain are exposed. So there's a higher risk for some disruption in neural circuitry and so on. Okay, so when we're talking about primary injuries, this is a really important distinction. So we're basically talking about the consequences that are due to the biomechanics of the injury. So these are injuries that occur essentially at the point of impact. Okay, so we're talking about skull fractures, contusions, or hemorrhagic lesions, and then this diffuse axonal injury. And this is sort of, again, another piece that's sort of outside of the scope of this presentation, but diffuse axonal injuries could be primary or secondary, or both. But suffice to say, these are the injuries that occur essentially immediately. There's less that we can do about these types of injuries than we can with the secondary injuries. I think probably the best way to avoid a primary injury is to not do the thing that puts you at risk for a traumatic brain injury. Well, that's not always possible, right? Motor vehicles put you at risk for an injury. So you're going to say you're not going to be in a car, you're not going to drive. Well, that's not necessarily realistic. But I wanted to introduce this concept to you all. This is a really crude slide, but I love it because I think it serves its purpose. So when you look at this picture, this is really illustrating the distribution of contusions. So what I was talking about a little bit ago, these hemorrhagic lesions. So these are essentially bruises in the brain. And when you look at this, you can see, so the black scribbles essentially represent areas of contusion. And you can see that there are higher concentration in some areas over others. So what we see here is this area here, we're looking at the temporal regions, and this is looking up at the brain. And these areas right there represent the orbital frontal regions of the brain. And there's a reason why those areas are a bit more susceptible. So if you look at this picture, this shows you the base of the cranial bone. Okay, so just ignore this basal skull fracture here. Okay, if you will. And that may make people cringe. I just wanted this for illustration purposes. What you know is, aside again from this basal skull fracture, this is a typical looking base of the skull. And what's important to point out is, what you'll notice are these bony areas have a higher concentration up front than they do in the back. Okay, so when you look at the posterior aspects of this vault, you'll notice, and I don't know if this picture does the greatest job of illustrating this, but you'll notice it's a little bit of a smoother area in comparison to up front where there's these bony ridges. Now that becomes a problem when the brain is in motion. Okay? When it's moving around, there is a great deal of force that's transferred to those internal structures when the brain starts to move around. So remember when I was talking a little bit ago about the coup contra coup effect, and I'm talking about throwing the basketball against the ball, and you have this ricocheting effect. Well, unfortunately, there's less room for the brain to move around up front than there is in the back. Because you have these smooth surfaces, and it is in the back, and it's a wider area, it's a wider surface area. So the problem then becomes, when you have enough force to put the brain in motion and it's moving around, it's brushing up, as you say it lightly, brushing up against those bony areas, and it's causing bruising in these areas that we refer to as the temporal regions of the brain and the orbital frontal regions of the brain. So if someone were to say, okay, I know that I had a brain injury, but my doctor never told me where the injury was, or where the lesion was, or however it's being told to us, a good guess would be, I bet it probably affected those areas of the brain. And the reason why I keep bringing this up, and in a much more abbreviated way, I will share these kinds of slides with patients. And the reason why I find that important is because of this. This may have already been mentioned, and even if it hasn't, it's worth restating. For many people, brain injury is an invisible injury. Okay? Unless there is an obvious trach scar or some sort of physical limitation. Most people don't know that someone else has had a pretty significant brain injury. And there's obvious indicators when someone's had more of a severe injury, but by and large, to look out in this crowd, I wouldn't necessarily know if someone in this room has had a brain injury. I may ask some leading questions that may give me some indication, but by and large, you don't necessarily have to wear your vulnerabilities on your sleeve. So that could be good and bad, can't it? Right? So we don't want people to necessarily think of us as disabled, if you will. But at the same time, we also want people to have altered expectations for us as we're going through this stage of recovery. Because things are different. Okay, so obviously, the effects that I just described certainly have an effect on thinking, emotion, behavior, and so on. It's not uncommon for families, patients to say, really it's more families saying, I just don't understand why so-and-so is acting this way. I don't understand why they're so, they may not use the term, but disinhibited, or why they're acting like a jerk, or why their personality is different, or why they just can't remember something when I keep repeating it to them over and over and over again. And of course my response is that, they're doing this over and over again. I always like to say, well, how's that working for you? Not so good. And stop it. Don't. Right? That's what 7 years of graduate school taught me. Right? So I think this is important because what it does in some ways, and it doesn't explain everything, but it does demystify that a little bit. So if you were to look at this and you have sat through this presentation and you know that memory difficulties, executive function, behavioral control problems are common following brain injury. If you were to look at your loved one through this lens and you accepted the fact that they had these bruises in these areas of the brain, might your expectations be different for them? Maybe, right? And I think it's also important for the patient who's experiencing this to understand why. They may experience this phenomena that Dr. Wolf talked about a little bit ago, the pseudo-Waller effect. Why do I keep crying when I'm not tired, or when I'm not tired, when I'm not sad? Or why am I laughing uncontrollably when I don't particularly find this funny? That can be very, very confusing, not just for the people around that individual, but them themselves. So understanding these sort of internal mechanisms, I think, are really, really important. So I don't want to belabor this too much more than I already have. I do want to talk about just some of the other phenomena, consequences of brain injury. You will hear this term used very frequently, this diffuse axonal injury. And so that's the shearing of the protective coating of the axon. So the white matter is being sheared as a result of those forces at play that we discussed earlier, those acceleration, deceleration, rotational forces. So the best the best analogy that I can give you is if you think of spaghetti and you take it and you twist it. That's kind of, in some ways, a good way to think about shearing of axons. And again, I find fault with this term diffuse. Yes, they are often widespread, but there is a bit of a predictable pattern that goes along with some of these. A lot of times it's that transition between gray matter and white matter that I showed you just a little bit ago. Gray matter weighs differently than white matter. So what that tells us is they probably move at a different rate when they're set in motion. So then consequently, those transitional areas between gray and white matter are mostly affected. That's where the stretching occurs predominantly, and there's some other areas as well. But this is the mechanism for deep coma, arguably for loss of consciousness, and so on. And here's a depiction of that. Okay, another one. And then this is as an example of diffuse axonal injuries that would be a result of a motor vehicle accident. You get the idea. So these secondary injuries, we can spend a lot of time talking about the dynamic processes that underlie these types of injuries. But what I really want you all to know is we talked about primary injuries being the direct result of the biomechanics of the impact or the initial result of the injury. For secondary, these are the more delayed consequences. And this is really due to the biophysiology of the injury. So these are a little bit later effects. Now, it's not, these are not necessarily 100% controllable or preventable, but management of these secondary injuries is really the reason why people are living following an initial severe traumatic brain injury. Way back when, the base rates of survival for following a severe traumatic brain injury were much, much lower because there wasn't this attempt to identify these consequences and manage them early on. Now, there are standards of care that require the treatment team to monitor for these kinds of sequelae, if you will, or consequences, and intervene before this leads to death. So these are much more preventable than those initial areas or those initial injuries. You know, and it's interesting. You know, we talk about a lot of these things to protect the skull and offset the occurrence of traumatic brain injury. And the best example that I've ever been given as far as why sometimes that's not as effective as we would like it to be. I've said this many, many times when I do this presentation. I think it's another point that's worth repeating. The best example that I can give, if I have my pre-doctoral intern sitting in the crowd. So let's say that I asked her to catch this egg and throw across the room. She has a pillow. She's going to catch the egg. I'm going to throw the egg. Let's say that I throw with enough force, and it makes it to her. She catches the pillow. The shell essentially stays intact. So the skull. However, all the contents inside of the egg were moving as it was in the air. There's very little to nothing you can do to prevent that. So we would assume, well, the skull's intact, therefore there wasn't the brain injury, right? But we're overlooking all those other other processes that are playing out that are much, much harder, if not impossible to control. I've just illustrated some of these different types of bleed, epidural hematoma. So this is a bleeding within, around the brain with the middle meningeal artery is sheared. Then we have a subdural. There's a bridging vein that is often sheared that can lead to a bit of a slower bleed. Just one thing to point out real quickly without getting too carried away with some of the physiology of this. When we're talking about flow rates, it's important to note that venous blood moves a little bit slower than arterial blood. So when we have a vein that is sheared, that may bleed slower than an artery. So these subdural hematomas, sometimes it's the case where someone has an injury, they seemingly are okay at first, and then they decline. That could represent the evolution of a subdural hematoma. So that bleed is building up over time, and we're not talking years. We're talking within a short window of time. The point is, all the more reason to continue monitoring, especially in those early stages of recovery. Now, I'm not saying that my daughter who fell off the arm of the chair was at a high risk for subdural hematoma, but let's say someone was in a motor vehicle accident where there was an impact at a high rate of speed, that certainly would raise concern about the evolution of these different types of bleeds. Okay? I'm going to speed through a lot of these in the interest of time. I'm not going to walk through these herniation syndromes, but essentially, as I stated earlier, there's very little room for the brain to move when you introduce a new content. So in other words, if you have a bleed, all these structures get pushed, well, mostly downward. And if there's compression of the brainstem, that's where death can occur. Okay, moving right along. So saving the best for last, right? The neuropsychological consequences. Neuropsychological consequences are, of course, very common. And they can take many, many different forms. A lot of times we see impaired attention, vigilance, distractibility, ability to shift or divide your attention. The patient may become quite distractible in their treatment. And some of our treatment providers in the audience certainly are well aware how impaired vigilance or distractibility can really alter the course of treatment. Processing speed. So this is a common consequence, and really I say difficult to identify a physiological substrate, but essentially, when we're talking about those axonal injuries, when there's shearing, when there's effect in those areas, it's difficult for those signals to move as quickly as they need to. So someone thinks a little bit slower or has a hard time coming up with the right answer. It takes them a little bit longer to do things. Memory, and I mentioned a little bit earlier about why this is fairly common, because of those areas of the brain that we know of that mediate memory, so those temporal regions of the brain. So forgetfulness is certainly not uncommon. And a lot of times when I will evaluate a patient following a traumatic brain injury, we'll ask sort of, what is your appraisal of how things are going? How is your memory? And it's not uncommon for folks to say, oh, it's fine, I remember things from 30 years ago. We don't expect necessarily that type of memory to change, right? It's learning new information. Those structures that are responsible for learning new information and retaining that are the most vulnerable. Okay, so someone may remember 30 plus years ago, but they may not remember conversations that they had earlier in the day. Okay, and I go through just kind of a brief description of some of the anatomical sites that are mostly to blame for memory problems. Executive functioning, essentially what we're looking at is ability to problem solve, reason, and to control one's behaviors. So you may work with someone or know someone who's had a traumatic brain injury, and they have a problem with controlling their behavior, they have disinhibition. And that is often the result of frontal lobe injuries that I showed that picture of contusion just a little bit earlier. Speech and language, there can be difficulties with fluency or word finding following a traumatic brain injury. So what you'll see is, before I get into this piece, certainly there are cognitive effects. Some of these cognitive effects look different in traumatic brain injury versus other disease processes. I didn't go through all the areas of neuropsychological areas, and go through all the areas of neuropsychological function that we assess in our testing, because I really wanted to highlight some of the areas that are most commonly affected and to tie that into the cause that I mentioned just a little bit earlier. Psychiatric consequences are very common. Depression is one of the most common psychiatric consequences of brain injury. I leave this slide up here too because I love sharing this with my trainees. I love when people say, oh, the literature in neuropsychology or psychiatry is crystal clear. And then you have a statistic like 6 to 77%. So it either never happens or it happens all the time. So I wanted to keep that in there. But essentially, it's, from what we understand, about 40-ish% of survivors of brain injury have some type of mood disorder, which is actually about double the uninjured population. There's a lot of differentials that we need to think about. Sometimes there's apathy or indifference following brain injury. Someone just isn't as interested in life or a particular hobby as they once were. Emotional lability that we talked about a little bit ago with a pseudoball or affect is uncontrollable tears. That may not be a sign of depression. It may. Apathy in and of itself may not be depression.
Yeah, I couldn't decide whether to fit this in, whether it was you or Dr. Wolf, but I don't know if this is something you experience or not, but, you know, I wanted you to address people who have closed head injuries. We've had a number of people who are very aware of their symptoms. Do you run across populations that are either unaware of the change that they're experiencing and or in denial? And does that have anything to do with the severity of the injury?
Very good question. So denial is something that is often thrown around when someone goes to their provider and say, you know, I don't have any problems. Everything is just the way that it was before. That is typically the last place you want to go as far as explaining what they're not understanding, right? So the way to answer that question is the brain is obviously responsible for so many different things, and one of the aspects of brain functioning that makes us unique is our awareness of the world around us. And often we see that in the right hemisphere or frontal lobes, those types of things. If someone has injuries in those areas, there's a phenomenon that exists where someone essentially neurologically doesn't have the capability to be aware. So it's really unfortunate for those folks to be labeled as being in denial when in fact it's that their brain will not allow them to be aware of what's going on. Now, it doesn't mean that someone couldn't be in denial, but usually my default is if someone comes to me and clearly they're impaired and they say otherwise, more times than not, it's that neurological limitation. And that's very, very difficult. So then do you spend the time trying to convince them? No. We need to work around that, and our therapists in the audience could probably give all kinds of examples of the way that they would modify their environment. Essentially, as a treatment provider myself, I would not spend a whole lot of time trying to convince them that they have a problem. I want to manage their environment to keep them safe. Now, the consequence may be that they get a little irritable and upset because why can't I drive? I would, now this isn't, keep in mind I know there's individual differences here, but I would rather have someone be irritable and upset rather than being unsafe and putting themselves in jeopardy, hurting themselves or others. That's a very good question. I'm glad you asked that. So that is definitely something that we need to think about. PTSD is certainly something that we need to rule out. You know, it's interesting, and the role of insight is interesting because we will see different types of depression manifest at different points of recovery. So if I have someone that is depressed earlier on, I may start to think that there is a result of biochemistry being affected from that initial injury. Sometimes the depression will set in later on because as we see the brain heal, those areas that were preventing them from being aware start to heal, and then they become aware, and then they realize, gosh, now I have limitations. Believe it or not, sometimes depression and anxiety is a good sign of recovery, because it means those areas are intact. And the last thing I want to leave you with is when you think about what is all involved in being depressed or anxious, it really is a lot of thought, isn't it? You have to think about the past, be aware of the present, anticipate the future, synthesize all that information. That requires a lot more brain function, I think, than we even realize. When someone is at that level, when they become depressed, stress, that is sometimes a little bit easier to roll our sleeves up and do something about that. This is going to sound horrible, but I would much rather have a patient depressed and anxious. We can do something about that, right? That is a level of awareness and insight that we can intervene. I don't want them to stay at that level. But if someone has no awareness of what's going on, there's very little that we can do other than try to keep them safe. Okay? It's a good point. I'm glad you mentioned that. And I don't know that I'm going to have too much more to say in the interest of time. One last just picture here. Sorry. Jumping through this because you guys have my slides. Oh, I love this thing. Think not only the kind of injury, think of not only the injury, but the kind of head. So we're talking about, all these effects to the brain, but also think about the brain that this happened to. Keep in mind that everything I said is filtered to the individual personality. The way someone experiences memory typically is maybe different from one person to the next. Okay, so that is really important. Does anybody know who this is? Phineas Gage. This was yeah, poor Mrs. Gage, right? Because he was a very different person after this injury. Was this a closed or an open? Very did not lose consciousness allegedly. Right? So this is very much a open head injury that has unfortunately it happened, but it contributed to the understanding of behavioral neurology tenfold, of course, because we now understand the individual role of the frontal lobes much better than before, and how it affects behavior control and so on. So, I think in the interest of time, I'm going to end there. The very last slide, I got to get this in here. Takes a village, right? There's a lot of people that need to be involved in this continuum of care. I spoke about just a fraction of what some of the consequences are. Of course, what my biases are, the neuropsych and psychological effect. Recovery could not happen if we didn't have all these other disciplines, some of which you've heard from today. Inpatient, outpatient is often very much needed. Rehab psych for individual, family, and marital. Last thing, these injuries often affect a whole system of people that we cannot ignore. Family intervention, relationship, marital therapy, those kinds of things are often needed. I think I'm 15, 20 seconds over. So that's pretty good for me. That would be my
Thank you, Dr. Hart. And I also want to thank one of my former therapists who's in the room right up here. She's a patient restoration. I forget her name. But she's great. So thank you for everyone who helps patients use the same tools. And now our next person.
Student Joe Dumas.
They'll do.
Auburn.
Yes.
We got to project, we don't have a microphone.
Okay.
Blake will help you. It's on.
Is it different than what you emailed?
No, it's the same. Oh. Blake, it's the same one that's on the email.
Good morning. It's still morning. Next we have is an update to concussions in the NFL, which concussions is a mild form of traumatic brain injury. We have two fantastic speakers that's going to present to you today. The first speaker is Mr. Paul Anderson. He is a lawyer who's stationed out of Kansas City. He is a go-to now in this litigation for NFL with concussions. He created the NFL concussion litigation website, which is really a go-to website now for people to get first-hand knowledge on how to litigate these cases, as well as he has created this website. He represents several former and current NFL players from across the league. So you'll get to hear from the legal side of how this concussion litigation is going. Now, on the practical side, we have Speaker Marvin Washington, who will talk to you about a player's aspect to this concussion in the NFL. Marvin Washington was he was in the NFL for 11 years. He was a part of the 1998 Denver Broncos Super Bowl team. So he can really give you an aspect of how the NFL and concussion from a practical view. And with that being said, I give you Paul Anderson and Marvin Washington.
Well, thank you guys. I first want to start off by again acknowledging all of our veterans for your countless service and for all that you've done for our freedom. Without you guys, we wouldn't be able to enjoy days like this. So again, I'd like to thank all of you. I'd also like to thank Professor Drake for inviting me back again this year. It's always a tremendous experience to be able to hear gentlemen like Ben and Sean talk about the battles that they had to go through for our freedom. And then my good buddy Marvin Washington over here, I've recruited him today to be my timekeeper, so as soon as it gets to 11:30, if you see him tackling me, you know why. Marvin's going to add the real life perspective of what this battle that he's gone through, what the players have gone through against the NFL. I'm a plaintiff's lawyer in Kansas City, Missouri. I graduated law school in 2012. So I'm going to be coming at this from the plaintiff's side and an advocate of protecting brain injury victims' rights. How many of you guys have seen the movie Concussion with Will Smith? Good showing of hands. That movie is in fact a very highly factual movie, and it really dives into what led to the quote-unquote NFL concussion litigation and the subsequent class action settlement that arose from it. I represent about 25 guys, a team of lawyers and myself in Kansas City, players that have played several years in college and in the NFL. All of our guys have opted out of the settlement because we believe the settlement is inadequate in many respects. For some it is good, but for the majority of players, unfortunately, the way that the settlement has been crafted is it does not provide meaningful compensation. So today I'm going to talk about what led up to the litigation. You know, and in every dispute there has to be some factual basis that leads to the litigation. And so I'm going to start off. We've had a lot by the doctors today that talk about the science. So I'll skip ahead of that. I just hit the right. There we go. Okay, the bottom one. Skip ahead of the science and typical concussions and how concussion occurs. What this litigation is really all about, or what it started with, was chronic traumatic encephalopathy, and that is CTE. And CTE, it's been described in the literature dating back to the 1920s. Dr. Harrison Marbley first described it in boxers, and it was initially known as punch-drunk syndrome, or pugilistic dementia. And it wasn't until fairly recently, in 2002, and then thereafter, when a gentleman by the name of Dr. Bennett Amalu discovered CTE in a gentleman by the name of Mike Webster. Iron Mike Webster played almost 20 years in the NFL. He was a center for the Pittsburgh Steelers, and then played his last 2 years with the Kansas City Chiefs. Mike Webster was a center, so he was constantly engaged in repetitive brain trauma. One thing about CTE is it can only be diagnosed definitively post-mortem, and that means after you've died and you've had an inspection of the brain. And so Dr. Amalu was a Nigerian-born doctor who came over to the United States to study medicine. And whenever he first saw the game of football, he said, "Oh my goodness, what are these people doing? You have these massive men colliding into each other. God didn't make brains for them to be bashed." So he never really understood the sport. And he was a pathologist, a neuropathologist, and worked at the coroner's office in Allegheny County. And one day, Iron Mike Webster, who tragically died after a long battle of depression, showed up on his slab. And all of his texts were very excited because it was Iron Mike Webster, and they were getting ready to look inside Iron Mike Webster. Dr. Amalu didn't really know who he was, didn't have any understanding. He just was very curious as to why a gentleman in his mid-50s died so young and looked in such terrible health. He was able to convince his boss to inspect the brain, and what Dr. Amalu found was a pathology that's similar to what you've seen in boxers. And it was what he identified as CTE. He brought this to the NFL's attention. He published his findings in 2005, stating specifically that repetitive brain trauma from football led to his conditions and his subsequent demise and CTE. The NFL's response was contrary to what Dr. Amalu was thinking. He thought that the NFL would accept the idea with open arms. Of course, it was to the contrary. What the NFL said is, who is this Nigerian man who knows nothing about America's pastime and is going to try to abolish football altogether? So the NFL went on the offensive. And I'll drop back a decade before I jump into their direct attack on Dr. Amalu. But in the early 90s, whenever Marvin was playing, concussions were on the rise. Several players were starting to suffer from concussions. Merrill Hodge, they had previously suffered from concussions, but they were really never diagnosed in the way that they were starting to be diagnosed. And so at the time, Paul Tagliabue, the commissioner and a lawyer, was asked by the journalist, why does it appear that concussions are on the rise? And Tagliabue's response was, concussion is one of these packed journalism issues, frankly. There's no increase in concussions. The number is relatively small. The problem is, it's a journalist issue. And that was the NFL's response back in 94 and 95. And what we say is that was typical to what Big Tobacco did. And the idea of obfuscating the truth and linking it to some other issue. And so from that day forward, whenever Commissioner Tagliabue came out with these statistics, the NFL said, we need science to back this up. So the NFL convened a group of doctors, one of whom used to be Marvin's former team physician, Dr. Elliot Pillman, who was a rheumatologist. He was led with the task of leading the Mild Traumatic Brain Injury Committee, as the committee was called. And their job was to study concussions. So you have a group called the Mild Traumatic Brain Injury Committee. You would think the NFL, with all of its resources, would go out and hire the best doctors and neurologists and neurosurgeons, but instead they led it with a rheumatologist, a doctor that deals with knees and joints. And so for the next 15 years, the committee, quote unquote, studied the science, and this is what some of the conclusions that they came up with. In 2004, they published their findings in a very prestigious medical journal, and they stated no evidence of worsening injury of chronic cumulative effects from multiple concussions. Meanwhile, the literature said the exact opposite, that repetitive brain trauma can have long-lasting effects. And these are some additional findings. This was the Mild Traumatic Brain Injury's direct response to Dr. Amalu, basically saying his study about Mike Webster lacked any foundation. It was not based on science. And I find this statement very striking whenever they respond to him. And this is one thing that really smacks of somewhat incompetence. In fact, there was no known history of brain trauma inside professional football either. Whenever you're talking about football, it's a collision sport of of course there's going to be brain injuries, and I'm sure Marvin would have a response to the idea that there isn't brain trauma in professional football, which clearly it is a collision sport. So these are the rest of their findings that they published in the Journal of Neurosurgery from the period of 94 to 97. And this is one of the first things that they concluded. It can be concluded that mild TBIs in professional football are not serious injuries. That statement is what really led to a lot of the idea where coaches were telling players to rub it off, get back out there. And fortunately, I think this litigation and the players coming forward has brought a new sense of awareness to this sport and to concussions in general. The study of concussions has vastly expanded since 2005, 2006. Specifically, return to play protocols are now in place through almost all across the country. The state legislatures have passed laws mandating that if an athlete is suspected of having a concussion, he must be immediately removed from play, because it could potentially set in motion the chain of events of what's called second impact syndrome. And we just spent the last 3 years litigating a case against the NCAA in which we represented a family of a young man who played college football at a D3 school in Western Maryland, who was a fullback, the starting captain of the team, and over a 4-day period, blood was running from his forehead. He just did not appear to be himself. And over, his coaches said, "Get back in there, Derek. Get back in there, Derek." And finally, on the 4th day, he told his coaches, "My head does not feel right." And his coach said, "Stop being a PUSSY. Get back out there, Derek." Derek continued to play, took a subsequent hit, collapsed, and died 6 days later from second impact syndrome. And that's an example of why return to play protocols are so important, because your brain, after that initial concussion, is in a highly vulnerable state that any subsequent hit can trigger massive brain swelling and death. And that's, like, again, going back to this idea of why it's so important for anybody who's a coach or deals with athletes, that if somebody has a concussion, they must be removed until they've been cleared by a physician to return to play. So going back to some of the other NFL statements, they stated that second impact syndrome probably does not exist in any NFL players. That's somewhat true, in that second impact syndrome generally involves adolescence in which their brain is still in a developmental stage. But nevertheless, this statement that basically poo-poos the idea of a return to play protocol in which a player is removed after suffering a concussion. The next thing is they flat out denied any link between repetitive brain trauma and CTE, in which they stated no signs of CTE in active contemporary football players, and that our studies support that arbitrary return to play guidelines may be too conservative for professional football. At that time, it was common practice. The athletes suffered concussion, they got their bell rung, quote unquote, got their bell rung, they'd come over to the sidelines, have smelling salts, and be returned to play. Fortunately, things changed not too far after that, and we'll get into more of the physiology of CTE, but this is an example of what happens in CTE. CTE is caused by repetitive brain trauma, not just a single concussion, but instead it's a repetitive subconcussive brain trauma that's essentially inherent in the game of football. The constant brain bashing, in which your brain is rattling around the skull. And it's called, the NFTs accumulate in the brain, and the clinical symptoms of CTE often start with emotional and behavioral issues. Dr. Ann McKee, which I call the godmother of CTE, out of Boston University, has really led the charge subsequent to Dr. Amalu in publishing and studying CTE. And she breaks CTE down in four central stages. Stage 1, Stage 2, Stage 3, and Stage 4. We don't know exactly when it begins, when the clinical symptoms begin manifesting. There may be a latency period after the last trauma before it begins. So, for example, an athlete ends his football career, and 4 or 5 years later, the symptoms begin manifesting. Or it could be as early as the mid-20s. We've had experience with athletes who have committed suicide, unfortunately, at a very young age, and they were subsequently diagnosed with CTE. And let me just say that CTE is not isolated to football. Dr. Ann McKee published a study in 2014 in which she wrote about 4 individuals who were returning from the theater of war after various stints in Iraq and Afghanistan, who were hit by IEDs and had other traumatic brain injuries that occurred throughout their life and were subsequently diagnosed with CTE. We've seen it in hockey players, of course we've seen it in boxers, soccer players. So anybody who is exposed to repetitive brain trauma is potentially at risk of CTE. But there's still a lot more studying that is necessary, but certainly we are to a stage where we need to acknowledge the risk and ensure that those athletes that are engaging in these sports are informed about those risks. So I can guarantee you, whenever Marvin was playing, whenever he signed that contract, Marvin, did you know about the long-term risk of CTE?
No.
Right, and that's the typical statement you'll hear from the majority of NFL players. And unfortunately, this is a sad timeline that shows several former NFL players who died at a very young age and were subsequently diagnosed with CTE. So after the NFL engaged in this long blanket denial of CTE, Congress got involved. Congressional scrutiny is often one way in which change often occurs. So Congresswoman Linda Sanchez led the charge. She brought in Commissioner Goodell and other NFL executives and analogized their conduct to big tobacco. And from there, this occurred in 2009, from there I think the plaintiff's lawyers took note, my goodness, something serious is going on here. These gentlemen are dying at a very young age. Congress is now saying the NFL is acting just like big tobacco. These gentlemen deserve to be compensated. So thereafter, the first concussion lawsuit was filed, and it exploded into this massive litigation in which you had over 5,000 individual players filing lawsuits against the NFL. And there's a mechanism in place whenever there's lawsuits filed all around the country that essentially consolidates all the cases in front of one single judge. And that became the battlegrounds for the NFL concussion litigation in Philadelphia. So the entire crux of the case was based on negligence and fraudulent concealment, the fact that the NFL knew or should have known about the long-term risk of repetitive brain trauma, yet they never informed their workforce about these risks. And then worse, the idea of flat-out misrepresentation about the risk whenever the NFL's Traumatic Brain Injury Committee was publishing studies in journals stating that there is no link. The link does not exist, and that it's due to some other genetic factors or drugs and alcohol. So Pandora's box was busted wide open. I think the NFL knew that, my goodness, we have something serious on our hands. We need to try to get this case wrapped up and resolved. And shortly thereafter, after about 2 years of litigation but no discovery, the NFL announced with the plaintiff's lawyers, the class action plaintiff's lawyers, that a settlement has been put together that would compensate certain individuals and put an end to the litigation. So the typical course in class actions, the class members are notified, they are given an opportunity to say whether they want to stay in the deal or opt out of it, and the overwhelming majority of players ended up staying in the deal. And Marvin and I will talk about whether they were actually made aware of their rights. Marvin, he contacted me, you don't mind me sharing the story. He contacted me after the deadline in which a player had to opt out, and Marvin said he didn't even know really what the settlement was about. And we've heard that from a lot of former players what the NFL and class council say and what the district court and the Third Circuit said is that everybody was adequately apprised of their rights. But, you know, the NFL was able to get a massive release in which it released all players' claims. In other words, they cannot move forward with litigation. Instead, their sole rights come out of this settlement. So although the number sounds big, up to $1 billion, it's an uncapped settlement, up to $1 billion has been set aside to compensate certain individuals who have one of these quote-unquote qualifying diseases. And what it is level 1.5, level 2 is dementia, then you have Alzheimer's, Parkinson's, and ALS. The problem is the settlement has all but excluded the essence for which this case started, and that is CTE. Only a small number of individuals will ever be compensated for CTE, and those are individuals that fall within two bookends of January 1, 2006 and April 22nd, 2015. So I'll give you two examples of what that means. Mike Webster died in 2002 when he was diagnosed with CTE shortly thereafter. Since he falls outside of that range of January 1, 2006 and April 22nd, 2015, his family is entitled to nothing. Meanwhile, a gentleman who certainly deserves to be compensated is Dave Dorson. Dave Dorson played for the Chicago Bears. He committed suicide in 2011, was subsequently diagnosed with CTE. Since he falls within this book frame, these two bookends, his family will receive approximately $2.3 million. And then on the other side, you may have recently heard about Kenny Stabler's death, the snake quarterback for the Raiders. He died 4 or 5 months after April 22nd, 2015. He was subsequently diagnosed with CTE, yet his family will receive nothing. And that's the future for a lot of these NFL players, is that if they do tragically die, and it's determined that they have CTE, their family will receive nothing. And that's really is what drove the objectors to object to the settlement, is the settlement's unfair and quote-unquote unfair and arbitrary treatment of CTE, that it is entirely excluded compensation for the overwhelming majority of players who may suffer from CTE. Because currently, although the statistics are somewhat biased in that the majority of people who go to have their brain examined are those who have been suffering, the statistics are daunting right now. 92 to 94% of all former NFL players whose brains have been examined have been determined to have CTE. And Dr. Ann McKee says that she wouldn't be surprised if every NFL player has CTE. So that's really why it's so important, because right now we're still in such an early stage of the diagnosis and trying to find a treatment. Science is vastly is getting there, but right now we still can't diagnose CTE definitively in a living person. So you have so many players out there who are asking questions, what's wrong with me? And they see all this literature, but they don't know exactly what's going on. So that's why we are trying very hard to be able to diagnose this in the living. Various neuroimaging is now being used. Some clinical diagnoses are being made, but the holy grail is really being able to identify the diagnosis in the living, so then we can move on to the next stage, which is treatment, ensuring that we don't have any more former players die tragically from suicide and other terrible deaths, so we can continue to heal these wounds. So this is some of the neuroimaging that's going on. There's 3 different outlets. Boston University is leading a group. Dr. Sam Gandy at Mount Sinai University and Dr. Julian Bales and Dr. Small and Dr. Lawler are also trying to use neuroimaging to diagnose CTE. This is the control brain, a brain that hasn't been exposed to repetitive brain trauma, and 1 and 2 are brains that have been exposed to, players that have been exposed to repetitive brain trauma. And yes, go ahead.
So wait for you to finish your.
No, that's okay.
I was just, what are we looking at in terms of, I mean, is that like NFL 1, somebody who's been playing for 2 years, and NFL 2, somebody who's been playing for 8 years? What are we looking at?
Yeah, that's exactly right. It's based on, so one thing about CTE is we just do not know, we believe it's a dose or an exposure. The more exposure, the higher fold the CTE is going to be. But yeah, NFL 1 was an individual who was like a quarterback, someone who was generally engaged in less repetitive brain trauma. Whereas the NFL 2 was either a defensive back or a linebacker who was constantly in the thick of it. But again, science is still trying to figure out specifically exactly, because we don't know how many hits it's going to take before you get to CTE, or before you get to the various stages of CTE. So despite the various objections, the settlement was approved. The objectors took it to the Third Circuit. The Third Circuit affirmed the case as well. The objectors are at the final stage, which is the United States Supreme Court. And as most lawyers know, the chances of the Supreme Court granting cert is less than 3% of all cases. So it looks like all the briefs have been submitted to the justices. They've been circulated. They're being circulated right now as we speak. We'll likely have a decision from the Supreme Court before Christmas whether the Supreme Court is going to take the case or affirm the lower court. And if the court affirms the settlement, then it becomes effective and it'll work out for the next 65 years, in which certain individuals will receive compensation. Fortunately, the overwhelming majority, according to the class counsel and the NFL's own actuarial data, will not receive anything. One final parting shot that the NFL did, or that the Third Circuit did state, was a win for former players and a win for hopefully the ongoing discovery and continuous publications and our increased knowledge of CTE, is that the Third Circuit affirmed the fact that there is a link between repetitive brain trauma and CTE. And the Third Circuit stated, after the NFL had somewhat acknowledged it, the Third Circuit stated in dicta, the sheer number of deceased players with the post-mortem diagnosis of CTE supports the unavoidable conclusion that there is a relationship, if not a causal connection, between a life in football and CTE. So although the NFL may have gotten a win through this settlement, I think it's now in a reported Third Circuit case that CTE is real and there is a link between repetitive brain trauma and CTE. I'm going to turn it over to Marvin, who's going to provide kind of his personal experience and discuss some of the great things that he's doing currently.
Good morning, everyone. Thank you guys for having me back. Thank you, Professor Drake, for having me back. And I definitely want to give a shout out and a thank you to the veterans. So, as Paul said, we can have days like this. Because we need days like this to celebrate our freedom. And I just want to thank the veterans. But getting on with the subject is, I believe I was a guinea pig. I played 11 years in the NFL. I played in the trenches. I played from 1989 to 1999. I know that seems like 10 years, but it's 11 years. But I was a guinea pig because there was no concussion protocol. There was no protocol return to play. And for the first 8 years of my career, my team doctor was Dr. Elliot Pellman, who Paul just mentioned, the rheumatologist, who he didn't tell you, he was at the time the NFL's commissioner's best friend, but he didn't tell you also this rheumatologist did not get his medical degree here in the continental United States. He got it from the University of Guadalajara in Mexico. And in the locker room, we didn't call him Dr. Elliot Pellman, we called him Mr. Pellman. Because as you became a veteran, you see that this guy put the team's interest, NFL's interest, and his interest above player safety. And they're still doing that to this day. As I said, I'm a guinea pig and a living witness. 1992, we were playing New England Patriots, and I wrote about this in the Players Tribune last December. We were playing the New England Patriots, and I got concussed. Went to the sideline, got the smelling salts. They asked me, was I okay? I said, yeah. They said, where are we playing? I looked up at the scoreboard, and they could clearly see me looking at the scoreboard. I said, we're playing New England. 2 or 3 plays later, they yelled goal line defense. I grabbed my helmet, ran back on the field. Playing defensive line, blew my assignment, touchdown went on my side. This is on film, you can see it. Played the rest of the game, second half. We go into the huddle, middle linebacker would call out the play. I would go down, get in my stance, and right before the ball was snapped, I would turn around and say, what was the play? I did this the whole third quarter, all the way to the fourth quarter, till finally my teammates was like, get him out of here. Went to the sideline, got dressed after the game. The next day we watched film study. I do not remember the game from that point on. So that was the NFL in the 90s and up until the 2000s, because they formed this head, neck, and spine committee in 1993, and Elliot Pellman was in charge of it until 2007. And then they got somebody that was worse than him, Dr. Ira Kaysen, who went before the congressional committee, and after he came out the committee, they called him Dr. No. Because when they was asking him about concussions, is there a correlation between concussions and CTE? No. Repetitive hits to the head, can it cause brain trauma? No. He said there was no valid, reliable, scientific, objective studies that said repetitive hits to the head do not cause brain injury, despite this information being out here for the past 70 years, since the 1920s. They call it punch drunk, or dementia pugilistic, shell shock, when you're talking about the armed services. But to me, it's all the closed head injury. And Stacy came up here and said 82% of the soldiers suffer from a mild TBI. That's what we're suffering from. And if you're talking about PTSD, there's a bunch of NFL players that are walking around with mood and behavior symptoms from CTE that's been written out the concussion settlement, which is a farce. I get into that later. But substance abuse, drug abuse, domestic violence, depression, anxiety, forgetfulness, lack of impulse control. Stop me if you've heard these before, because they mirror what's happening in the armed services. But I do give the armed services, and I said this last year, at least they're recognizing it. NFL can say that, but you better talk to the owners like Jerry Jones or Robert Irsay, who just came out last year, or Bob McNair of the Houston Texans, who said, we don't know where it comes from. You could get it from climbing out the pool. So they're still not recognizing that CTE, there's a direct correlation. But as he also said, we're working on it. So to me, as he asked me the question, did I know? I didn't know anything about it because it wasn't there. I played in the dark ages. Would I do it again? A lot of guys say, yeah. Me, I don't think so. This ensemble that I had with came with a jacket. I packed the day before. I always have to because I travel a lot. I always forget something. It's frustrating. I don't know if it comes with age or it's come from me being in the trenches for 11 years. I always forget something, and it's frustrating. So when I got up this morning to get dressed, I was looking for my jacket in my bag, and it wasn't there. Very frustrating. And I'm high functioning. Frank Gifford, iconic NFL player, played in the 50s, went to USC, All-American guy, retired from football, did everything right, had a Hall of Fame football career and a Hall of Fame broadcasting career. And when he passed last November, or last December, or October, Kathy Lee and his family donated his brain to Boston University, and they found CTE. So if Frank Gifford has it, what does that say about me? What does that say about the rest of the 20,000 former players that played in the NFL? And you talking about brain one for an NFL quarterback? What about a guy that played 3 years in the NFL, was a backup, but he banged every day at practice, but he probably had 5 years of college, 4 years of high school, 2 years of junior high, 3 years of junior high, and then Pop Warner. That's where we're starting this thing at. That's how far we're going back with this disease that the NFL does not recognize. And so I just try to tell it matter-of-factly. I really don't get upset about anybody except Dr. L.A. Pellman. And I told Paul last night if he was to walk into his room, I'd probably punch him in the mouth because I know what he did. I know he put guys' health, long-term health, at risk because here's the thing about football players. We all knew that we were going to leave the game and have some orthopedic issues. You know, look at my fingers and my wrist, and I walked, you know, I got to straighten myself out. Well, I knew that. I didn't know I was going to leave this game with a disease. And so it started to come into my sphere of information with Mike Webster. 2000, 2001, we didn't have, you know, the smartphones or whatever, but I read the paper every day. But you start hearing about Mike, and it's like, what's wrong with Mike Webster? What's wrong with Mike Webster? And then he died, and then Dr. Malo came out with, you know, his diagnosis of CTE. NFL did their deal, big tobacco, but then more players started dying. Jason Starowski, Andre Waters, Dave Dorsey, leading up to, you know, Junior Seau. But then the concussion lawsuit happened, and all these unscrupulous, and I'm sorry, attorneys who wanted to make some money, got in and started signing guys up. Then it became a class action deal. And out of that, 675, 775, you know who gets paid within 90 days, $100 million? It's their attorneys. So I don't hold out much hope that I'm gonna get anything out of it because I hope I don't. And the guys that do get something out of it, they definitely need it. Because this is ongoing and it's not gonna stop because my first year in the NFL, there was 4 offensive linemen over 300 pounds. By the time I retired in 99, 2000, there was maybe 4 guys 4 guys over 300. But when I retired, there was maybe 4 guys under 300. Guys are getting bigger and faster. And the doc was talking about that rebound effect. Well, think about going about 30, 35 miles an hour and you do that sudden stop with your brain and somebody's hitting it. And then that rebound part is you hitting the turf. They say concussions are going down in the NFL, but they are to a certain extent, but the back of the head concussions, they're staying level. And actually they're peaking up. They peaked up a little bit last year, they're peaking up now. You know, so football has a safety issue on their hand. And in 1950, the top 3 sports in America were boxing, horse racing, and baseball. Baseball's fine. Basketball is gonna be fine. The other 2 are events and fringe sports. If the NFL wants to continue to be the #1 sports league in America, be the #1 sports league as far as revenue producing in the world, they're gonna have to take care of this safety issue. That's why I still hold out hope that they're still denying it. But we're starting to see it. Since the NFL lawsuit was filed in 2010, youth participation is down 13%. High school participation has gone down. It's ticked down to the point where it's 3% in Texas. I'm from Texas. I know how big football is. When I grew up in Texas, there was 2 sports. There was football and there was spring football. So, so now you have moms that are making these decisions that I'm not gonna let my son play. And me coming out and speaking, and I've said this to people in the NFL and NFLPA, I don't want to kill football, I just want to make it safer. I want to make it safer so when you go in and these college coaches and you sit down on little Johnny's couch, you can tell his mother and his father that he's going to be safe, that his brain's going to be safe, that he's not going to have to deal with these mood and behavior disorders when he's 30, when he's 40, and when he's 50. That's all I want to do. But I have to speak out because I have so many guys that are suffering and suffering in silence, and there's no help out there for them. The help is coming not from the NFL. As Stacy asked me, where do guys go? They go to private sector to get it because there's a bunch of groups that are trying to solve this issue, but it's not the NFL. The NFL just gave, what, $100 million to concussions. 40 million of it for equipment, 60 million of it to study concussions and what have you. And my question is, why are you giving $60 million to something that you don't publicly acknowledge? What are you doing? That's big tobacco once again. Guys out here need help. There's a lot of people that are doing it, but the NFL, they're still trying to mitigate their liability. And everybody's talking about the reason why the ratings are down in football. You know, if you take a battleship in the ocean, it takes a long time for it to turn. This decline in ratings from the NFL probably started in 2009, 2010. So how are they going to stop it? You have to make the game safer. Because the NFL has a safety issue. Baseball has a pace of the game issues. The games are too long, but baseball is doing fine. Basketball has the length of their season. A lot of people, I don't watch basketball until the playoffs start. Football has a safety issue. It's a collision sport. It's a hard sport. It's a dangerous sport. But let's make it safer, because I love it, because there's a lot of life lessons in there. But I wouldn't let if I had kids again, I wouldn't let them play football, at least to a certain age. But I don't know if I would even let them play football, because there's so many other sports that can get them these life lessons from without the chance of getting this disease. And I've seen it in my ex-teammates and peers. I was just with them 2 weeks ago. We had a alumni game or alumni and a reunion. You see guys, you talk about their gait. You see guys, how's your memory? Their wives come to me. I'm an advocate, and I have certain products out that anecdotally can help with CBD. I get so many messages from Facebook, Twitter, Instagram, emails. I just got one this week. Hey Marvin, you know so-and-so, so-and-so. I was like, yeah, well, he's suffering from CTE. Can you call his wife? Because he's in the hospital, he just failed. And so they can't call the NFL, but my platform is such that they call me. And I don't have a 503 nonprofit, but I do, because I just give my stuff away to guys because they need it. They need help. From veterans also, I give it to them. But I say the Veterans Administration is ahead of the NFL. But the NFL makes between $11 and $12 billion a year. Don't think they can afford to help their players? And that $875 million, what is that, over 65 and 75 years? 65 years. And you take it to 32 NFL teams over 65 years. That's probably less than a couple $1 million a year. That's less than an average starter. That's what they're doing. And they're going to hold on to most of it, because the majority of the players are going to see nothing. The older you are, less money you're going to get. But when do these symptoms manifest itself? It takes time. CTE, there's a player that just passed a couple weeks ago, and I sent Paul, I believe, a text message or email. His name is Kevin Turner. Everybody thought he had MLS, because NFL players with these nervous system and brain disease were 4 times as more likely to get ALS, 4 times as more to get dementia, 4 times more to get Alzheimer, and we're kind of even with Parkinson's. But everybody thought Kevin had ALS. When they did the autopsy on him, came out that he had CTE, very severe case of it. And it's called CTE MMD. And there's another player that had it too. So now it's a different ballgame. Because now we thought we just had these mood and behavior disorders that can lead to suicide, now it can lead to death. But the NFL is still not acknowledging. And I say outside of this concussion settlement and lawsuit and what have you, the NFL is going to, in the very near future, they're going to have to set up a fine, because Roger Goodell, NFL commissioner, is always saying about protect the shield, and protecting the shield is being a good citizen and being a productive citizen and bringing no shame to the NFL. Well, you got 20,000 players, and a lot of them are having these mood and behavior issues. And they're going out, they're abusing drugs, We're also 4 times more likely to abuse prescription drugs also. So that's another issue. I had an ex-teammate of mine call me. He hasn't played in the NFL in 17 years. He was sitting in his mother's kitchen, looking into the laundry room, thinking about drinking some bleach because he was still taking 12 Percocets a day. He's lost his house, he's lost his family. He didn't know anywhere else to turn, so he turned to me. I'm helping him because he can't go to the NFL and get help. He can't go to the NFLPA, our union, and get help because, as I was told by somebody in upper management of the NFLPA, we represent current players. Despite a guy playing, like me, playing 11 years, probably giving over $150,000 of union dues to them, they don't represent me anymore. They represent current players, which I understand, but they know they have an issue, and hopefully it's going to be addressed in the next CBA, which is in 2020 or maybe sooner, because you can't have these brain damaged individuals out in general society and they're doing tremendous damage to themselves and to their families and to their spouses and to their kids. They are doing tremendous damage to them, and I hear the stories all the time. And a lot of guys are just dropping off the grid. You don't hear from them again, and they're suffering. And they need help, and it's not like, I'm not gonna compare them to people in the armed services. I definitely wouldn't do that. But these guys sacrifice a lot to play in the NFL and try to provide to their family. And they have this disease. And a lot of guys are successful after football, like Dave Dorson. This was a guy that was a Notre Dame Golden Domer, academic All-American captain. Worked for the NFL for a while. But once the disease, because the disease is gradual, then it happens all at once. He lost his business, he lost his marriage, had a domestic violence arrest about a year and a half before he committed suicide. I believe he was the NFL's Man of the Year at one point, but you can trace it back to the same thing that happened to Junior Seau. Junior Seau played over 20 years. Good guy. Loved Junior. Everybody loved Junior. Same issues, business, domestic violence. Junior got arrested for domestic violence, got out, and had an accident where he drove off a cliff. It was a suicide attempt. That was his first one that we know about. But he finished the job about a year later. And so that's why I said the NFL has to address this issue. Because if they don't, they're going to be a fringe sport. Why would I let my kids play football if they're going to leave with the disease? And why would we try to take this game across the pond to Europe, take it to Australia and New Zealand, when you can have you're going to have a section of society that's brain damaged? So they have to get in front of this. There has to be some type of help, and a lot of help is coming from the private sector. And Can I say what I do? Like I say, I'm a CTE advocate, and I try to help players. Well, and I help veterans also. I work for veterans organizations also. My thing is, and people say, well, Marvin, what do you do? I tell them I'm in the medical marijuana industry. And there's 2 main chemicals in the cannabis plant. There's THC, that's the part that gets psychotropic, psychoactive, gets you high and you're stoned. And then there's CBD. CBD is the part that has medicinal benefits, helps out the kids that have the epileptic strokes and seizures, helps out with the cancer patients that have that wasting or lack of appetite. It helps out with MS and asthma. And also the government holds a patent on CBD cannabinoid, patent 6630507, that said CBD can act as an antioxidant and neuroprotectant for the brain in relationship to CBD. And that's where I got into it, because I believe that the cure is not going to come from, or the solution is not going to come through equipment, because everybody's coming out with these helmets, these Kevlar helmets, these big helmets. Well, if that was the case, what about the soldiers that are in the war theater? Why don't you just make a better helmet, a better
Body armor.
body armor for them? You can't do it. or the people that are in the motorcycle accidents. So I believe it's going to come through science. And there's a lot of quack science out there with Russell Wilson for the Seattle Seahawks talking about he took concussion water, and even Tom Brady, I think, said he was wearing concussion underwear, something like that. There are a lot of guys out there, but the science is showing that CBD can be an antioxidant neuroprotectant for the brain. They're doing it over in Israel, which they're light years ahead of the studies because they got the government back and they've been doing it for the last 50 years. They're showing that it can be. And so anecdotally, that's what I give guys. When I say I help guys, I give guys. And I give it to them on 2 points. To quality of life, and it helps them with emotional behavior disorders, but also some of the medical practitioners in this country and then drug treatment guys, they're starting to give CBD because that's another thing that's eating at the fabric of this country is the prescription drug issue, but it takes away the cravings. Anecdotally, it's showing that it helps take away the cravings because you can't go from your Oxycontins and your Demerol and all this other stuff that you're taking to the stuff that they detox, which is just as poisoning. And so CBD is something that's non-toxic, non-addictive, and the research is not there because the cannabis plant is still illegal on the federal level. And they're opening up a little bit. It's coming along. We won't have enough research, but anecdotally, it's helping guys, and it's helping guys that I get to. And I take it every day. Show you what I take. This is a mist that I take, and I have one for discomfort. I have one for comfort and calmness. This is the one I take, and it's a mist that you spray underneath your tongue. And it's nano-sized, so it does the job of the liver, gets right into your membrane, passes the blood-brain barrier, and it helps me calm down. And I give this to one of my teammates who had an issue. He has 2 teenage daughters. And yeah, they're something special. But he has no middle with him. He's either at 1 or 10. And that's not normal. Sort of. Teenage girl or something. My daughter went from the 9th grade to 10th grade. I didn't know her for a whole year. But I did not go from 1 to 10 with her. And it helps them. I have another one, a CBD drop. This is for me. Because I take this, I can put it in my coffee in the morning, I can put it in my water, whatever. I take it because I'm trying to protect my brain and have quality of life. Because I do have some memory issues. That's why I'm here without a jacket. I do have some memory issues. That's why I let my girlfriend drive, go to the gym every morning. That's why I let her drive to the gym. Because when I go by myself sometimes, and I don't know if it's lack of attention or whatever, despite it being a mile from our place, sometimes I end up 5 miles. And I can't think like, man, what? How did you get here? So, am I high functioning? I believe I am. I believe you're genetically susceptible to it. But I do know I have some issues, and that's why I have to write down things and make sure I make a list, or else I'm going to forget it. I had a good friend from college yesterday. We were texting back and forth, and when I got busy, got on the plane, when I got the plane, she was texting me, and I was like, who is this? And she was like, it's Deborah, I've been texting her all the time. I was like, oh, okay. And she kind of laughed it off. But these things are happening with more frequency, so I'm trying to, when you say neuroprotectant, I'm trying to protect my brain. You talk about antioxidant, I'm trying to get this out of the brain. It's going to degrade anyway with old age, I imagine, whatever. But I played in the trenches, so I'm just trying to protect my brain. And I'm trying to help my teammates and peers and soldiers with something that's non-toxic, non-addictive. It's legal. This is industrial hemp CBD, so it's legal on the federal level, legal in the state of Missouri. And this is what we need to start looking at, because sometimes the poison is in the cure. Because I had another teammate that died of an opiate overdose, ex-teammate, but he's taking the prescription drug exactly the way the doctor told him to. And you find that a lot. They take the drugs exactly where they're supposed to. And so we're 4 times more likely to abuse prescription drugs. Why? Because we're being poisoned throughout our career with You say, Marvin, you're gonna play the game Sunday or next week. What do you need? Well, I'm gonna need an anti-inflammatory, so I'm gonna give you some Indocin or some Naprosyn. I kind of like Indocin because it's fast acting, it's better. All right? 2 days before the game, I'm gonna get me on a Tylenol 3 because I need to ease that soreness that's out of my body. Go play 60, 70 plays in the game, after the game, no, before the game, I need a pain blocker that's gonna make me feel like Superman, so I'm gonna take a Toradol. That's like an epidural on my side. They make my body feel good. No, I can't feel any pain. Then after the game, I'm gonna get me probably some Percocets to go well. I always go with Percocets. And this stuff is still happening in the NFL. Not too much of the Toradol, but there's still teams that use it, but this stuff is still happening. And guys are going out there, so they're abusing their body, and they put their heads at risk, and you want this sport to remain the #1 sports league in the United States, #1 revenue producing sports league in the world, it can't happen. It has to change, has to come. I'm happy to have these conversations because I have them as much information. We live in the information age, now everybody goes to their phone and computer and get this information. NFL knows it. All these products, they're at the executive level of the NFLPA. They just announced 2 days ago that they're looking at marijuana, which I told them, like, say cannabis, guys, but say marijuana. Say cannabis as for pain management and neuroprotective for the brain. They have to find some solution to their safety issue. So this thing is gonna happen. I believe that people in the NFL are smart enough, or it's gonna affect their bottom line, and we're gonna have a solution to this this safety head issue that the NFL has, and then maybe in 4 or 5 years, I can come back and I can recommend that all your kids and grandkids play football. Right now, I can't do that. So I thank you guys for having me.
There's a question.
Is there any questions?
Yeah, I've always been curious, do you know whether a helmet of a D preschool is as good as a Denver Bronco helmet?
Same helmet. Came from the same manufacturer, and that second impact syndrome, did you say his name?
Yeah.
Because I don't want to say his name.
Derek Shea.
Yeah, Derek. That was on his coaches. But he was wearing the same helmet that they're wearing in the NFL. So the equipment is the same. Equipment is the same in the NFL that these kids are trying to emulate. And football's a man's game. It's not a kid's game. Kids are trying to emulate what they see. So they have the same equipment.
Maybe a question for Paul. Marvin, certainly you know the answer. Paul Slide talked about the date, or the arbitrary dates of who was in that settlement, who's not.
Yeah.
Can you shed any light on where those dates came from and how that discussion evolved?
Yeah, I wish we had more time to do this.
Yeah, I know.
We had an hour, 2-hour conversation. So the dates, the way that they structured it, at least according to the components of the settlement, on the arbitrary CTE cutoff dates, is they picked January 1, 2006 as a date that any claim that had been filed or if somebody would have died, like Mike Webster in 2002. The NFL's argument is their claim would have been barred by the statute of limitations. And then on the opposite side, April 22nd, 2015, that's the date the settlement was granted final approval. And the NFL and class counsel's basis for which they're not going to pay for any future CTE claims is they say they don't want to incentivize suicide. They're saying since you can't diagnose CTE in the living, you can only diagnose post-mortem. NFL players, which is the most illogical
We're gonna go out and start shooting ourselves.
line of reasoning I've ever heard, is that they're just about killing themselves so they can get money, which is outrageous.
There's a question back there. Couple questions.
You're saying something about helmets, and I think people are under the false assumption that helmets prevent traumatic brain injury. What helmets prevent is a skull fracture, but they don't prevent traumatic brain injury. That's caused by the brain bouncing around inside the skull, and no helmet can prevent that. And my concern is that a lot of times players are given helmets, and they're not told that, and so they have the false assumption that this helmet is protecting me, when in reality they aren't. And I think that we need to do a better job of educating our players that your helmet doesn't protect you from concussion.
You're exactly right. And in our case, in the NCAA case Derek Shealy, we sued the helmet manufacturer because that exact same thing. Representative told the players, these are superior technology helmets, they're going to help reduce concussions. And we did several focus groups and polls of the general population, and exactly what you just said. Most people believe that helmets protect against concussions, but no, their only purpose is to prevent skull fractures, which they do a good job of that, but they do not do anything regarding concussions, and manufacturers are capitalizing on that.
And I think that makes it more dangerous because then with that false sense of security, people take greater risks.
Absolutely. That's a nail down there, but.
My question, are you aware of any research comparing this type of injury to another sport such as rugby that's also contact sport?
You're having athletes that are been diagnosed with CTE rugby. The thing about rugby is, fortunately, you don't have this false sense of security where you get players launching their heads with missiles so they can be protected by the helmet. But nevertheless, several players in New Zealand and Australia and England have been diagnosed with CTE that were rugby players. So we see it all across the spectrum of any contact sport. And even, I think what we'll see in the future of even PI litigation, PI regulations, you're going to start seeing individuals who are going to be diagnosed with CTE who had a history of repetitive brain trauma and subsequently in a car wreck, and somebody's going to have a diagnosis with CTE. Yes, sir.
Football's it's the biggest business in the world, right? Can it be made safe in your opinion as a lawyer who's involved in trailblazing litigation, or should it just be banned?
Well, certainly our position is not to end football. Just what Marvin said, our role as lawyers, we want to make sure this game can survive and continue to thrive. But, and in fact, over the last 4 years, we have seen so many tremendous developments occur. Statewide, we now have concussion protocols, return to play protocols, and the cornerstone of this entire issue is education. I do believe we take the position that athletes, kids, certainly little kids, Pop Warner, they should not be engaging in repetitive brain trauma. Instead, we should play flag football up until adolescent age, up until we get to high school. We can engage in the fundamentals, but without the unnecessary brain trauma. But we are at a tough crossroads, and science is going to continue to develop and emerge. But I think football can stay. We just have to stop the denial, and we have to make education the forefront. So people can engage in that risk balance analysis whenever parents are sitting around the table. Should we let our child play a sport, or should we look at baseball or some other sport?
And once the NFL officially acknowledges the causal link between head contact and brain trauma, do you think that will change the nature of the game in terms of the player's relationship with the team and their contract?
Yeah, you're exactly right. I mean, Marvin would speak to this better than I did, and he lived it. You've got doctors that are essentially still beholden to the team, and that relationship needs to be changed, where the doctor is the patient advocate.
I just wrote a paper for I'm involved with the NFL Harvard study, and I just wrote a paper about team doctors. And how can you be a team doctor and you're paid by the team and you're going to the team for your livelihood? And a lot of this is a cottage industry for these doctors to get associated with the team, and that boosts up their private practice. But what's even more egregious than that is you got 23 NFL teams right now where they're being paid by a medical facility to provide care to the players. So the players need their own advocate, they need their own doctor, they need their own medical board that's going to look out for them, because you cannot trust the team doctor to look out for your best interest. Like I said, they're going to put the teams first, because the best ability that athlete, an NFL player has is availability. You got to be out there, but somebody needs to be looking out for you.
I am sorry to shut this down. So next year, we're going to do 3 hours.